Hi, I'm Mikal from Prague ICU, and today you will learn everything about acid-base balance in ICU. Normally, pH ranges between 7.35 to 7.45. Energetic metabolism is a continuous source of acids. Volatile acid includes CO2, carbonic acid respectively, which is excreted by lungs. Non-volatile acids include sulfates, phosphates, lactate, ketoacids that are excreted by kidneys. The balance only remains if intake and output of acids is equal. Average pH is 7.4, which is slightly basic and leads to a constant battle of the body against acidemia. To sustain the pH level at this narrow range, the body developed compensatory mechanisms. Henderson-Hasselbalch equation is the cornerstone of acid-base balance. Formulates relationship between pH and buffers. Bicarbonate buffer is the quantitatively most significant buffer system. To be able to calculate pH of the blood, we just need to know what is the level of bicarbonate and CO2. Both parameters can be simply obtained from the Astrup blood sample. If the pH is less than 7.35, patient has acidosis. If the pH is above 7.45, the patient develops alkalosis. Blood gas test by Astrup is another cornerstone. It's a bedside test on a small sample of blood taken anywhere in the circulatory system, but preferably arterial. pH, PCO2, and PO2 are measured directly. PO2 provides information on the oxygenation status. PCO2 shows ventilation status and is affected by hypo or hyperventilation and acid-base status. Bicarbonate ions and base excess or deficit are calculated from derived Henderson-Hasselbalch equation. Level of hemoglobin is also measured in Astrup. Here we can see the normal ranges of arterial and venous blood gas test by Astrup. The most valuable results are taken from arterial Astrup, where normal pH ranges from 7.35 to 7.45. PCO2 ranges from 4.6 to 6, PO2 from 8.7 to 13.3, bicarbonate ions 22 to 26, base excess ranges from minus 2.3 to 2.3, and then oxyhemoglobin levels 92 to 98. What base excess means? Base excess is defined as the amount of strong acid or base that must be added to each liter of fully oxygenated blood to return the pH to 7.4 at a temperature of 37 degrees Celsius and PCO2 of 5.3 kilopascals. It describes metabolic component of acid-base balance independently on the actual level of PCO2. Base excess doesn't differentiate between primary metabolic disorder and metabolic compensation. BE is normally close to zero and ranges from minus 2.3 to plus 2.3. Positive base excess is associated with metabolic alkalosis, and in contrast, negative base excess corresponds to metabolic acidosis. Electroneutrality principle, Gamblegram, is another cornerstone of acid-base balance. If you learn or memorize Gamblegram, you will master the acid-base balance. Electroneutrality principle means that the sum of all cations always equals sum of all anions. On one side, cations, mainly sodium and potassium, but also calcium and magnesium, and on the other side, anions, mainly chloride and bicarbonate, but also other negative anions such as albumin, phosphates, exogenous acids, and others. Anion gap is used for the evaluation of metabolic acidosis to determine the presence of unmeasured anions. Equation of anion gap is therefore sodium plus potassium minus chloride and bicarbonate anions. Normal range is from 8 to 16 millimoles per liter. Hence, the anion gap contains the difference between above-mentioned cations and anions, and it includes plasmatic proteins, organic acids, inorganic acids, or exogenous acids. We talked about anion gap, but we need to also know the corrected anion gap. Normal anion gap is dependent on serum albumin and phosphates, but in hypoalbuminemia, which is a common finding in ICU patients, the anion gap is greatly underestimated because every albumin decrease of 1 gram per liter decreases the anion gap by 0.25 millimoles. Thus, the true value of anion gap in hypoalbuminemia is higher than the value calculated from the classical equation. So the equation that is used to calculate corrected anion gap is anion gap plus 0.25 times 40 minus albumin level. Osmolal gap is another important term. We should measure the osmolal gap in any patient with an unexplained high anion gap acidosis, coma, or suspicion of ingestion of a toxic alcohol. Osmolal gap is most often created by alcohols. Hospitalized patients have increased risk of iatrogenic propylene glycol intoxication in case of high-dose lorazepam administration in sedated patients. The osmolal gap is the difference between measured serum osmolality and calculated serum osmolality. The serum osmolality is calculated as 2 times level of sodium plus urea and glucose. Osmolal gap equals osmolality measured minus osmolarity calculated, and normal range is from -10 to +10 milliosmoles per liter. Osmolal gap above 12 milliosmoles per liter suggests presence of osmotically active non-ionized substances. To be able to correctly interpret acid-base balance, we need to know what is the relationship between acid-base balance and ions. In case of potassium shifts, acid-base disturbances cause potassium to shift into and out of cells in exchange for hydrogen cations. In acidosis, we observe hyperkalemia, and in alkalosis, hypokalemia. With regards to calcium, serum proteins act as a buffer with their ability to bind or release hydrogen ions in exchange for calcium ions. Around 40% of plasma calcium is bound to serum proteins. In acidemia, we observe elevated levels of ionized calcium, and in contrast, in alkalosis, there is observed a decreased level of calcium. Here is an overview of acid-base disorders. On one side, metabolic disorders, in which we see changes in bicarbonate, and on the other side, changes in PCO2 that correspond to respiratory acid-base disorders. In metabolic acidosis, we observe decrease in pH, which is in accordance with decreased levels of bicarbonate. There are 2 types of metabolic acidosis: hyperchloremic or with increased strong acids. Hyperchloremic metabolic acidosis, in which anion gap is normal, so-called NAGMA. This is caused by loss of bicarbonate. Now we need to get back to Gamblegram. Loss of bicarbonate cations then must be compensated by increased plasmatic concentration of chlorides. Causes include following. You can see the mnemonic DRAC: diarrhea, renal tubular acidosis, Addison disease, or chloride intake. The other type of metabolic acidosis, which is more common, is associated with increased levels of strong acids. In this case, anion gap is increased, so-called HAGMA. Again, we need to get back to Gamblegram, which helps us to understand why there is an increased anion gap. Increased anion gap shows presence of acid ions, presence of strong acids. There is another mnemonic to better remember the causes: CULT, ketoacidosis, uremia, lactate acidosis, or presence of toxins. How do we treat metabolic acidosis? We should always treat the underlying cause of MAC, and the acidosis usually resolves spontaneously. MAC is treated with sodium bicarbonate only in limited conditions, such as pH below 7.1 or base excess, which is less than -10. In hyperchloremic MAC, every MAC caused by loss of bicarbonate can be treated with sodium bicarbonate. In diarrhea, we should maintain fluid load and monitor electrolytes, and in renal tubular acidosis, depending on type, Sodium bicarbonate is needed in large quantities, sometimes in the longer term, plus potassium supplements. In case of MAG related to the presence of strong acids, we should correct the underlying cause, glucose and insulin in diabetic acidosis, treat shock and sepsis appropriately, use specific antitoxins. In mild to moderate acidosis, add supportive measures, such as IV fluids and respiratory support, and when pH is less than 7.1, add sodium bicarbonate infusion. Sometimes we might observe low anion gap metabolic acidosis. Its etiology include, again, think of Gamblegram to better understand. First, conditions with increased chloride levels. Second, in case of decreased unmeasured anions, which leads to increase in chloride or bicarbonate. And third, and last, in patients with increased unmeasured cations, which leads to decrease in sodium levels. Bicarbonate is administered IV as an 8.4% solution of sodium bicarbonate that contains 1 millimole bicarbonate per milliliter and is very hypertonic. Sodium bicarbonate is not a universal treatment of metabolic acidosis and is used only in limited selection of patients. It's generally better to treat the underlying cause of acidosis. Bicarbonate use is burdened with a number of adverse effects and is indicated for treatment of severe acidosis. Indications include MAG2, loss of bicarbonate, in hyperkalemia patients, in sodium channel overdose, or as a urinary alkalizator. Adverse effects of bicarbonate use include hypernatremia, overcorrection to alkalosis, hyperosmolality, hypokalemia, and ionized hypocalcemia, tissue necrosis secondary to extravasation, impaired oxygen unloading, increased lactate production, or headache, muscle pain, nausea, or vomiting. Metabolic alkalosis is associated with increased pH and increased levels in bicarbonate. We divide metabolic alkalosis to chloride responsive, with urine chloride being less than 20, and chloride unresponsive, with urine chloride above 20. Treatment includes, in hypochloremia, normal saline, in cases of increased levels of bicarbonate, acetosalamide. Metabolic alkalosis with increased levels of bicarbonate are caused by retention or addition of bicarbonate, overcorrection of acidosis, hyperaldosteronism or Cushing, in citrate increase, which subsequently metabolizes to bicarbonate, such as in massive transfusions or during citrate CVHD, in hypoproteinemia, in depletion of magnesium or potassium, or in dehydration. Causes of metabolic alkalosis related to decreased levels of chloride include vomiting, nasogastric suction, loop and thiazide diuretics, or post-hypercapnia alkalosis in ventilated patients. Again, metabolic alkalosis causes include alkali administration, GIT hydrogen loss, excessive renal hydrogen loss, or intracellular shift of hydrogen. Respiratory acidosis is associated with drop of pH and increase of CO2. It's caused by alveolar hypoventilation of any etiology. Retention of CO2 compensation takes days, and treatment includes treatment of the underlying cause, bronchodilation, sedative drug antagonists, or mechanical ventilation. Respiratory alkalosis is caused by acute and chronic process. Always treat the underlying cause. What are the compensatory mechanisms in acid-base disorders? Dysfunction of one organ system is compensated by increased function of the other. Goal is to reach the neutral pH and stabilize bodily functions. Metabolic disorders are compensated by changes in mini-ventilation in a matter of minutes. Respiratory disorders are compensated in hours to days by change in renal and hepatic metabolism. Metabolic disorder leads to respiratory compensation, which includes increased ventilation with subsequent decrease in PCO2 or decreased ventilation with increased PCO2. Respiratory disorders lead to renal compensation, which includes increase in hydrogen and ammonium excretion and bicarbonate reabsorption. Or in respiratory alkalosis, we observe decreased reabsorption of bicarbonate. Here is a useful figure summarizing compensatory mechanisms in acid-base disorders. In metabolic disorders, we can utilize Boston rules. In metabolic acidosis with decreased levels of bicarbonate, we can quantify the expected decrease or increase of PCO2. In metabolic acidosis, the measured level of bicarbonate is divided by 5 plus 1. In metabolic alkalosis with bicarbonate above 26, actually measured bicarbonate is divided by 10 and then 2.6 is added, which gives us expected level of PCO2 as a compensation of metabolic disorder. Then you can see the calculations for expected compensations of respiratory acidosis and respiratory alkalosis. It's not uncommon for patients to have more than one acid-base disorder at once. If the PCO2 and bicarbonate are deflected in the same way, it may be difficult to distinguish the primary disorder and compensation, especially if pH is neutral. If the compensation is not appropriate, this is indicative of a second acid-base disorder present. If PaCO2 is too low, there is an additional respiratory alkalosis. If PaCO2 is too high, there is an additional respiratory acidosis. If the bicarbonate is too low, there is an additional metabolic acidosis. And finally, if bicarbonate is too high, there is an additional metabolic alkalosis. Now let's talk about mixed acid-base disorders. In some occasions, we see combinations of metabolic disorders, metabolic alkalosis and metabolic acidosis, such as in protracted vomiting, where there is hypochloremic alkalosis, and hypovolemia-induced lactate acidosis, or in patients with vomiting and diarrhea, where there is hypochloremic alkalosis and we see losses of bicarbonate, or in patients with hepatorenal failure. Also, we can observe mixed metabolic and respiratory disorders, complex disorders, such as in septic shock plus ARDS, or in patients with hepatic failure with respiratory insufficiency, or during salicylate intoxication, where we see metabolic acidosis and respiratory alkalosis. To perfectly understand acid-base balance, we need to go through and interpret Stewart-Fensel model. Stewart-Fensel brings different approach to acid-base disorders assessment. One of the main benefits of the Stewart-Fensel approach is the accurate calculation of unidentified strong acid anions. This model shows that pH is determined by 3 independent variables: strong ion difference (SID), concentration of weak acids, albumin and phosphates, and PCO2. What is strong ion difference? SID. Strong ions are cations and anions that exist as charged particles dissociated from their partner ions at physiological pH. We can calculate SID as strong cations minus strong anions. In practice, it's sodium plus potassium plus calcium plus magnesium minus anions, which are chloride and strong acids. This difference creates an anion gap which is filled with 2 main components: bicarbonate anion and anions of weak acids, which are albumin and phosphates. Routinely, the SID is calculated as level of bicarbonate plus albumin plus phosphates. Changes in SID and ATOT essentially define concentration of bicarbonate ions and are therefore causes of metabolic disorders in the acid-base balance. As part of Stewart-Fensel approach, there exist 5 steps to assess the acid-base disorder. Acid-base balance can be analyzed in 5 steps using routine biochemical blood tests and the aforementioned principles of electroneutrality. Goal of this method is to clarify etiology of changes in base excess and reveal any acid-base disorders. 5 steps include sodium-chloride difference, albumin level assessment, detection of strong acid presence, comparison of base excess, and respiratory component. First step is to assess the sodium chloride concentration difference, as these ions are predominant in assessing SID. Any deviation from the mean value of 34 millimoles per liter shows presence of acid-base disorder caused by excess or deficit in chloride. It is also of quantitative significance as 1 millimole per liter sodium minus chloride difference results in 1 millimole per liter base excess change. Here is one example. In a patient with difference between sodium and chloride of 24 millimoles per liter, this means 34 as normal value minus 24 corresponds to approximately base excess minus 10. Again, normal value should be 34 plus minus 2 millimoles per liter. If the difference is less than 34, patient has hyperchloremic acidosis. If the difference is above 34, patient has hypochloremic alkalosis. Second step aims to albumin level assessment. Albumin is the principal weak acid in plasma, and its level is an important part of the AB assessment. The normal value is considered to be 42 grams per liter. What you always need to take into account is that every 10 grams per liter of albumin accounts to 2.5 millimoles of anions. Albumin base excess effect can be therefore calculated as 0.25 times 42 minus measured albumin. Again, decrease of albumin is respected in gammagram and leads to increase of bicarbonate, causing alkalosis. See this example. Patient's albumin is 22 grams per liter. Therefore, there is 2 times 2.5, it means 5 millimoles less of anions, which leads to increase of bicarbonate. The patient is more alkalic. Base excess is plus 5. Step number 3 is the detection of strong acid presence. How is it with lactate base excess effect? Lactate is an important strong anion, routinely measured. Lactate base excess effect can be calculated as 1 minus measured lactate. Again, per gammagram, increased lactate leads to decrease of bicarbonate that leads to metabolic acidosis. Again, we can recapitulate the anion gap corrected to albumin. Corrected anion gap enables detection of circulating strong acid even in hypoalbuminemia. If lactate is not the cause of increased levels of strong acids, the disorder is caused by presence of an unmeasured acid. Differential diagnosis of MAC with increased anion gap from clinical context is needed. Mnemonic cult. Step number 4 is a comparison of base excess. The first 3 steps enable us to calculate a predicted base excess. BE equals sodium minus chloride effect plus albumin effect plus lactate effect. This predicted base excess is then compared to the actual measured base excess on the strip. Base excess predicted versus base excess actual. This reassures us on etiology of the complex AB disorder. Any difference between these two values represents ions contributed to other plasma constituents, both measured and unmeasured strong acids. After lactate is subtracted, the amount of unmeasured strong acid is revealed. As the last step, the PCO2 and pH is checked for presence of respiratory disorder. Boston rule for PCO2 level in metabolic acidosis differentiates between respiratory compensation and superimposed respiratory acidosis. Predicted PCO2 level for the present AB disorder is calculated as level of bicarbonate divided by 5 plus 1 kilopascal plus minus 0.3. Use the actual bicarbonate value, not the standard one. Another example, patient with metabolic acidosis having bicarbonate of 16, then the expected PCO2 should be 16 divided by 5 plus 1, which is 4.2 kilopascals. The Boston rule equation is slightly different in patients with metabolic alkalosis. Boston rule for PCO2 level in metabolic alkalosis is predicted PCO2 level for the present AB disorder is calculated as level of bicarbonate divided by 10 plus 2.6 kilopascals, again plus minus 0.3. Example is, we have a patient with metabolic alkalosis with bicarbonate of 42. Expected PCO2 then should be 30 divided by 10 plus 2.6, which is 5.6 kilopascals. Let's go through acid-base disorders in practice using Gamblegram. I know that it looks horrible, but it will definitely help you to more understand the topic. Again, all here is about electroneutrality, cations versus anions. As we said, SID is the difference between measured cations and anions. To simplify the equation, we can just use sodium minus potassium, as they form the majority of cations and anions. If there is decrease in SID below 32, as seen in the Gamblegram next to the first arrow on the right side of the figure, this decreased SID is caused by increased level of chlorides, which obviously needs to lead to decreased levels of bicarbonate, as it must respect the electroneutrality. This scenario leads to metabolic acidosis. In condition with increased SID, levels of chloride go down. Hence, there must be an increase of bicarbonate. This leads to alkalosis. In case that there is decreased level of albumin, second arrow on the right side pointing towards Gamblegram, levels of bicarbonate will increase to respect the electroneutrality. Patient has hypoalbuminic alkalosis. Last scenario is dedicated to increased levels of strong acids. If their levels increase, levels of bicarbonate will go down to respect the neutrality, hence leading to acidosis. Now let's take a practice using our clinical case. We have a patient with subarachnoid hemorrhage. 3 days after brain surgery at ICU. Didn't receive any nutrition for 48 hours. Patient is intubated on a mechanical ventilation. This is the patient's routine arterial blood gas test. Step 1. Sodium chloride difference is 36, 147 minus 111, which is 2 millimoles per liter above the normal value of 34. In terms of base excess, it's plus 2 millimoles per liter for step 1. Step 2. Measured albumin is 20 grams per liter, hence 2 times 2.5 millimoles per liter for each 10 gram per liter decrease of albumin from the standard of 42 grams per liter accounts for another 5 millimoles of positive base excess. Step 3 looks at the effect of lactate. Our patient has a normal level of lactate, but there is corrected anion gap of 26.9 millimoles per liter, which means the presence of strong acid, as the normal value of anion gap is much lower, around 12. Step 4 focuses on base excess. Predicted base excess as a total sum of base excess calculations in steps 1 to 3 is plus 7.1 millimoles per liter. But as we can see, our patient has actually base excess of minus 7.2. Hence there is difference of 14.3 millimoles per liter that accounts to unmeasured acid. The patient was without nutrition for 48 hours and has starvation ketoacidosis. Step number 5 evaluates the respiratory component. As we can see, our patient has, despite ketoacidosis, normal pH. When we apply the Boston rule for acidosis, 18.3 divided by 5 plus 1 give us predicted PCO2 level of 4.66 kilopascals, but the measure PCO2 is 3.75, which shows us the superimposed respiratory alkalosis. To conclude, this patient had high anion gap metabolic acidosis and respiratory alkalosis. And that is all for now. I hope that this presentation gave you several tips and tricks to master the topic of acid-base balance. See you later and stay tuned for next interesting educational videos from Prague ICU.